How's everyone doing? Are you hitting that after lunch slump? I'm sorry. I'll do my best. We'll do our best to keep you awake. And if you're really good, there might be some chocolate opportunities later on. We'll see. These are kind of low ceilings. See how it works. All right. We're going to introduce ourselves here. So I'm Michelle Lange. I'm an occupational therapist in the Denver, Colorado area, and been working in assistive technology, including seating and mobility, for a long time, and I really like it. But instead of talking about assistive technology a whole lot today, we're going to be waxing philosophical a little bit. Want to introduce yourself?
Yes, sir. So my name is Filipe, Filipe Correia. I come from Portugal. I've been in the industry for 25 years now. It's a long time. And I work in all the levels of the industry, except clinician, because I'm not a clinician. But I used to be a dealer, distributor, working for manufacturers. So, having the chance to do assessments with clients and R&D also. So happy to be here.
Great. So we'd love to know a little bit about you. How many of you are clinicians, OT or PT? Great. How about, since it's late in the day, I can't think of another term. How about someone who is acting as a supplier for the equipment? Great. Working for a manufacturer? Great. Just here because you had nothing else to do today. All right, got a couple. All right. Any specific goals, things you want to make sure that we address in this session here today? There's that dog in the back again, I think. Yes.
I have a couple different things, including PowerPoint, pictures, examples, and we've got the chair, and the parent is like, this is not what I thought it would be.
Okay, so helping the parent or the caregivers understand this is what you're going to end up with on delivery day, so there's not a surprise. Yeah. How to get the message across. Any other goals? Yes. So how to provide language of how to transition from one chair to another? You mean like it's time to replace a chair, or maybe we're moving from manual to power, or either of those? Okay. Yes, sir.
Yeah, managing people's expectations. What they are really expecting.
Yeah, managing people's expectations, figuring out what the expectations are, and then addressing that. Okay, great. Other goals? That should keep us busy. Yes.
Faces, ATP, OT, PT, and family.
Well, that's exactly what we're going to be doing. So how do we get everyone on the same page? You've got a lot of people around that table and they're not all on the same page. How do we get there? Okay, great. And you had a goal also?
Yeah, I just want to make sure my evaluations are as comprehensive as possible. I feel like I learned a lot of other ahead of my evaluation because I forgot to ask it, and now I have to go back and do a bunch of extra work. So just making sure that initial evaluation is nothing slipping through the cracks, and we're really capturing as much as possible in that, first introduction typically with the
Great. So trying to make sure you do everything you need to during the evaluation so the client doesn't have to come back and we don't have to keep filling in the gaps later on. Okay, great. Yes.
Defining roles and assessment of the PT, for example, the lead, the supporting, who in the ultimate makes a decision for both of you, is it one of you? Because sometimes I find there's a bit of confusion. You'll have there'll be an assessment, and then somebody will be popping in and saying, "Oh, we need to do this." So, the roles kind of become blurry.
Right. So figuring out everyone's roles on the team and who gets the final word, or how do we make a decision together? And that's different in each setting, right? Each depends on a lot of things. Cool. Well, I promise to keep you awake. Filipe, you want to keep them awake too?
I'll try.
Okay, cool. So tell the person next to you your favorite cookie. And I'm sorry we can't provide them to you, but tell them your favorite cookie anyway. What's your favorite cookie? All right, is this where you start? Conflict or? I don't remember. We're on like slide. No, we both do this. And then I'll hand it over to you. All right, any weird cookie choices out there? No, kind of standard. I see people waving at each other. That's all right. All right, how many of you said chocolate chip? Oh, yeah, always a lead. All right, conflict of interest. I don't have any conflict of interest when it comes to building consensus.
Me neither.
All right, here you go. Have fun.
So what we're covering today. Okay, so we're gonna, sometimes the team members may have some kind of difficulty achieving this consensus, being agree, upon a common goal or common ground, if you like. For example, if you have one team member that may be reluctant to move forward with power mobility, without consensus, the client may never get their power mobility. Okay, so it's really important that we are all in the same page. So we need to be have an eye for that consensus. So we're going to address those building consensus strategies throughout this day or throughout this course. So we're going to present a number of case studies that will illustrate a lack of consensus and strategies to get team members to be on the same page. We're not going to discuss clinical evaluations. We're not going to talk about assessments or what we need to do in terms of assessments. We're just going to present the clinical cases as an example for building this consensus. I think it's important that we all understand that. And get your phones because we have this app that the polling app that you guys gonna need it. Okay. So what we expect that you guys bring from this course is to list at least 3 barriers to achieve the team member consensus. Be able to list 3 common scenarios when consensus building may be challenging, and be able to describe strategies to build that consensus. Okay. So when we talk about doing an assessment, there's always industry challenges, right? This list is very long. I come from Portugal and I teach all over the world. And I think US is not different from the rest of the world in this, at least. The first problem that we always have or challenge is going to be funding. The second is going to be funding. The third is going to be funding. So funds is always a problem. We know that. Okay. Then we have products. Thank God that we have a lot of options. Okay. So we have a bunch of different manufacturers, sometimes with similar solutions, but we do have different options out there. So that's good, but it could be a problem when we're trying to reach consensus. The last one that we have on the list is playing well with others. And this is what we're trying to address today. So that we know that we are a part of the team. We are not the team. We are just a small part of a bigger team. Okay. So what is the definition for consensus? Definition, a general agreement about something, an idea or opinion that is shared by all the people in the group. Okay. So synonymous, accord, concurrence, concurrency, antonyms, that.
You can read.
Yeah. So I guess you have the same problem as I have.
Yeah, and I work with speech therapists. It's really quite embarrassing at times.
But anyways, complete disagreements, dissensus. Okay. A genuine leader is not a searcher for consensus, but a molder of consensus. Okay. So the barriers that we have for consensus, as a part of the seeding and a mobility evaluation team, we're going to expect to have varying goals and expectations. So we're going to have always team members that have different goals and expectations. We're going to have people that have different levels of knowledge and experience. Okay. And we are going to have different philosophies, perspectives of opinions. And then we're going to have hierarchy of roles. Someone was talking about that, right? So knowing whose voice is stronger than the next one on the team member. But one thing that we need to understand is that normally, when we're doing an assessment and we find a solution, that's not the only solution most of the times. We have other options. It's just a question of, measuring what is more important to a certain client in a certain situation. Okay, Michelle?
Thank you. Okay, so Filipe went through a number of the barriers to consensus. Let's dig down into each of these a little more. And a lot of these are goals that you've already mentioned. So first is that we've got all these people around the table, and different team members have different goals and different expectations. And we need to figure out what those are if we're going to successfully move forward. So this is just an example. As Filipe said, we're not going to necessarily come to any clinical conclusions, an example of where we have a lack of consensus. So let's say we have a client who won't use his footrest hangers. So his feet are just hanging out because his goal is he wants a very small footprint on his chair so that he can navigate through his small apartment. But the clinician on the team wants those footrest hangers on there, because they want to make sure that they're distributing pressure well on that leg, that there's no swelling in the feet as a result, etc. And the supplier wants the footrest hangers on there so this guy doesn't break an ankle and come back and blame the supplier for it. Here's another example, and we're going to go into each of these in more detail and talk about building consensus in a little bit. And that's where you get to use your phones and participate as well. So here's another example where we might have varying knowledge and experience among team members. So let's say we're working with this little girl here, and the private PT has heard about a new intervention, and it can help this client to sit up with better trunk control and maybe facilitate movement for this little girl. So she really wants this private PT to look at a wearable garment that's going to help achieve that goal, and is very resistant to building in a lot of support to the wheelchair seating system. But the evaluating OT in this case, who has more experience and knowledge in wheelchair seating, believes that the wearable garment won't be adequate for this little girl, and that we need to build in some more to the seating system. And mom is stuck in the middle. So she has two therapists telling her two different things, and she's not sure what to do. We also might find that different team members have different philosophies of treatment, or perspectives, or just opinions. We all have opinions, right? So perhaps someone on the team has insisted that this new wheelchair seating system include an anterior seat slope and a more closed seat to back angle to create that task performance position. But another clinician on the team has said, no way, we're not doing that. We want a more traditional seated position to allow for function as well as a position of rest. And the supplier has her own opinion, but is concerned that the clinicians will not listen to her or respect her input because she's just a supplier, right? I'm not making any opinions, but this is a scenario here, right? That often happens. And then our final barrier that often comes up when we're trying to get everyone on the same page is that hierarchy of roles. Let's say this client is evaluated in a classroom setting, and the school PT, who maybe has a little bit of a chip on their shoulder, doesn't believe the client needs a new seating system. But the evaluating clinician and supplier note that the client is in fact not in a good position at all. They're in quite a bit of posterior tilt, kyphosis, neck hyperextension in the current seating system, and they believe new seating is required. Challenge then is, as was mentioned when we were talking about goals, who gets the final say, or better yet, how do we get everyone on the same page? So this is, oh, this is your slide, huh? This is my slide. Okay, thank you. We got to make sure we're on the same page. My favorite way of trying to build consensus is to take a few steps back and find some common ground that everyone on the team shares. And that often means a shared goal. So perhaps someone is saying, my goal is to get a power wheelchair. That's not really our main goal. If we take a step back, the main goal is we want to provide mobility for this person. A power chair might be one way of doing that. A joystick or a head array might be a way of doing that. An ultralight manual chair might be one way of doing that, but it's mobility. And if we take that step back and we can find, sometimes it's several steps back, if we can find a goal that everyone around that table can agree on, we can often build from there. And then we talk about, okay, there's multiple ways, as Filipe was mentioning, of achieving that goal. Let's keep in mind the common ground, common goal, and then we can discuss how to best get there. So again, something so basic that everyone can agree on it. Okay, so talking about pediatric power mobility as an example, let's say the team is evaluating a child for a power wheelchair. There's a lack of consensus whether to pursue power or continue to work on self-propulsion, even though it's very, very inefficient for the client. So what is the common ground or goal? So now we get to practice our poll. So take out your phones and you're going to start by putting in the number. So the number that you're going to be sending a text message to is 22333. And then the message you're going to send is Michelle Lange, no E this time, 332. And then hopefully you'll see the poll. So, yeah, you're way in the back there, huh? So first, send a text to 22333. And your message will be Michelle Lange. Ooh, someone got it. 332. And then you'll see the poll and choose your answer. Let's see what people say. You know, just because you work in seating and mobility doesn't necessarily mean you're tech savvy, right? This can take a little work. All right. I can't see how many people have answered, but apparently everyone has answered the same. So our common ground could be, yeah, you got to make sure the other one's working, right? Our common ground could be get a power wheelchair for this young man. It could be keep working on developing manual wheelchair propulsion. It could be I want to win no matter what. Or our shared goal could be we need to find efficient mobility. And yes, thank you for winning the fight. But yes, our goal is how do we find efficient mobility? And that allows us to then move forward. And we might have to keep revisiting that goal. Someone might say, well, we're going to keep working on developing self-propulsion, right? It's like, well, maybe as long as we're achieving our goal of efficient mobility. And keep in mind that all these options are options and are tools. It's not our main goal. Okay, so now we're going to return to our barriers. Thank you.
Thank you. So remember this gentleman here that didn't want to use the footrest, right? So you want him to have a small footprint of the wheelchair. That's his goal. So no hangers on the chair. The clinician says, no way, we need to have a better pressure distribution. So we need the hangers. I don't want the swallowing of the feet. And the supplier says, I don't want to get sued if something happens, right? So what is the common ground? Are we trying to get a better positioning? Are we concerned about the accessibility, efficient mobility, the footrest hanger angle? How you guys feel? Okay. Interesting. Fun. Okay, I think accessibility is winning by far, right? So common ground probably it is accessibility. How we're going to get there if, everybody agrees that not having angles on the chair could be a problem, then we need to find a solution because what we want is to have better accessibility. Okay, agreed? Second case, finding this common ground for this little girl. So private PT has heard about this new technology that will help her to sit upright with less products into the system. So she doesn't want that conventional seating system. She wants something that she can wear. The OT says, no way. She needs a lot more support. So we need to have more built into the seating system. And the mom is confused, right? I have a PT saying something, OT saying another thing. So what it will be the common ground for this? Upright seating posture, the least amount of required postural supports, increasing trunk control, or restricting movement.
If you're having any trouble with the pole, feel free to ask someone in your row that has successfully gotten in there.
Hold on. Like Michelle was saying, I don't know if you guys heard it, that's interesting. Because for us, probably upright seating posture will be the common ground. But this is why it's so difficult sometimes to get this common consensus or the consensus between the team, because everybody has different ideas and perspectives and goals. Okay. So upright seating posture would be, in our opinion, the common ground here. Okay. How we get there, that's a different story. What we need to do, what products we need to use, do we need to work with angles? Do we need to work with a lot of different things in the seating system? That's a different discussion. Okay.
Just gonna go back to this for a sec. I think we lost our mic over here. Thank you. I think it's because you were standing there at the lavalier. We're good. So we had a little disparity here. Any questions or comments about this common ground? Yeah.
It depends on how much time they're in the chair versus out of the chair.
That's a good point. So depends how much time perhaps they spend in the chair versus out of the chair and what the tasks are that they're doing in those various positions, because perhaps that wearable garment would be a good option out of the seating system in that case. Yes.
In general, I think the whole, you were saying flex this lacking consensus. So for me in the last one, even though there was an overwhelming majority for what was considered the right answer, I still wanted to hear what the other people were thinking that chose the other ones, because maybe I'm missing something. So I think that also reflects what may need to happen in a team dynamic is examples is pretty clear what people are thinking. Others, it's like, not clear. So it's a good example because it's frustrating for me that I don't know what everyone else is thinking.
Sure. Let me just repeat the question real quick since we're being recorded here. So thanks, Cindy. Those are good thoughts. Cindy was just saying she'd like to know what people were thinking behind some of their choices on the last poll as well, because a big part of building consensus is hearing each other. And sometimes literally reflecting that back to let someone know, I heard you. I'm paraphrasing what you said. Did I hear you correctly? So that everybody's heard around the table, and that can often help us move forward and identify a shared goal as well. Absolutely.
Michelle, this goes to the classic case of form versus function,
Mhm.
with A being form and C being function. And those of us who naturally go to function could answer C, those who get form is more important could answer that.
So perhaps an example of form versus function, I think, I'm gonna grab you in a sec. I think that some of this comes down to a philosophy of treatment too. So because different people have different goals of seating, is our goal to improve postural alignment? Is our goal to improve function? Is our goal to a more therapeutic goal, like increasing trunk control, or is it a combination of those? So that varies too. Yeah, Trish.
I was just gonna say, I think part of it too is just the shared language. So like, you can sort of almost look at those two in a similar way. So like for me, for function, I was thinking upright sitting posture would allow them to increase the function of their.
It's not turned on. Thank you.
Of the upper extremities to be able to be more functional, whereas you're not, the goal might not be to actually increase their ability to control their trunk. You're really trying to stabilize the trunk, but I think it could be a language issue as well. Like maybe you're just understanding the question differently than somebody else.
That's a good point. I think another part of building consensus is education of team members too. So someone might bring up a concern, and it's important to flesh that out. Like someone might say, I want to increase their trunk control, and it's important to define that. What's your goal? Is your goal that they can sit up with less support? Is your goal to address that in therapy? Is your goal for the seating system to somehow increase trunk control? Yeah.
Sometimes,
Oh, thank you.
sometimes it's missing the user experience. Maybe they both have different ideas what should be best for the customer, what for the client or the patient, like long term, but the customer is facing the challenge of actually using it. So it depends on, each one has its own objectives. So
Mhm.
it could be both, but also thinking about what's the best or the easiest to implement, and then have a forward conversation.
Right. Good points. Awesome. Yeah, you just, thank you. Okay. Any other thoughts before we move on? Because there was definitely a lack of consensus on this scenario, right? And you could see where if any of us are around that table and there's this lack of consensus, even if somehow we came up with, okay, here's our recommendation and sent it home with this young lady, it's more likely that the outcome's not going to be very good, right? Because not everyone is on board. And then we end up with, what do you mean you never use your chair? And it just sits in the garage, right? And none of us want that. We want a successful outcome. Cool. Okay. So here's another example. And this can be a very controversial one, I find, in our field. Do we place someone in more of a task performance position? Or do we place someone in a position where they can find that they can be functional in that position, but also rest in a position, which is a little more traditional seated position? So what is the common ground? Also, an important aspect here is that the supplier feels like she can't chip in because she will not be heard. This is where there's a hierarchy issue too. So there's two perhaps rather strong-willed therapists that are not in agreement with each other, and a supplier feels like no one's going to listen. So what's the common ground in this situation? Who's choosing option D? All right, looks like our answers have finished. So we have a lot more consensus here. So we had a choice of, do we choose an anterior seat slope? Do we choose a position of rest? Do we choose a seated posture that promotes function? Or the supplier wins? After all, these therapists are really being annoying. They should have a chance, right? So most people selected posture that promotes function. Anyone want to say why they chose that? Don't worry, we're all about consensus today. Yes. Oh, let's give you the microphone because of the recording. Sorry.
Well, I think you could ask the customer what he does for a living. So if it's either rest or actual like office work, it should depend on what the user actually needs, not only the idea of each of the therapists.
That's a great point because we have to know the context of which this person's going to use their equipment and see if we can match that to the environment or the task. We have one back here.
I think the function is the part that's gonna be variable across clients, but
Mhm.
the goal is to improve the function, whatever it is.
Okay, so function's going to, that's all right. The function's going to vary between clients and the ultimate goal is to improve function. Yeah. So I think teasing this one out a little bit is that a position of rest might be a decision, an anterior seat slope might be a solution, another decision. But a seated posture that promotes function could represent a large amount of solutions. It's more of a goal of we want this person to be as functional as possible. That could include an anterior seat slope. It could include a position that for some clients provides more rest. It might mean that the supplier wins. It hopefully means everyone wins, especially the client. But it's a goal that has numerous solutions. All right, now we're really going to get into philosophy. This is mine. Okay, thank you. Thanks for keeping track because I keep thinking, is it still my turn? All right. Any of you take philosophy in college or high school or anything? Yeah, boy, that's some heavy thinking. I thought math was hard, right? And then you take philosophy. But I think it's important that we look at why do we do what we do? One thing that I've really learned over the years since I get to do some education as a part of my job is it makes you think about, well, what do I do and why? Because it's really easy to just get in there with a client. It's like, okay, here they are. I'm ready. Go do my thing. But we need to think about why are we doing what we're doing? What drives that? And is that a good way to do things or do I need to reconsider? There's three main philosophies of our interventions, why we do what we do in an evaluation. The first is therapeutic, that the seating system and the client's posture within the seating system should primarily have a therapeutic goal. Specifically, this often includes increasing trunk and head control and sometimes stretching tight muscles. For example, let's put elevating leg rests on there for that person with tight hamstrings, that sort of thing. Anatomical is the seating system should keep the client in as symmetrical a position as possible, and that trumps therapeutic goals, and it can trump function, alignment, orthopedic alignment. And then finally is a more functional intervention philosophy where the seating system should optimize client function, even if that means that there might be some compromise on perfect alignment, or there might not be a therapeutic benefit. Therapeutic benefits are traditionally seen more as occurring outside of the wheelchair seating system in a functional philosophy. So tell the person next to you what you think your intervention philosophy is and why, and don't forget to be nice to each other. After all, we're at the International Seating Symposium. I didn't actually accidentally doing your slides. Okay, good. I'm losing track. No, I think I go through hierarchy. Is what I had.
You still, I'm gonna do the 28 to 30, so I think this is like 25 or 26.
Okay,
Because you, I think you have another case there.
okay, cool. Yeah, that makes sense. Just losing track. I wasn't expecting there to be as much consensus on some of this. It ended up being a good discussion. So how are we doing on time?
Good.
Yeah, we're fine. Because we have till 3:45, right? Yeah, yeah. I'll give them another minute. They seem to be having good discussion.
Yeah, you can give them more because we are close to the end.
Yeah, that's true. We're doing really well.
And see, that's what I would meant when the discussion of cases and the instances on the board, because you know what we need to discuss.
Yeah.
Thank you for stepping in because I was moving too fast.
So I've got, first I was surprised that there was that one question especially had such a variety. Everybody would feel like they chose the wrong one.
Yeah.
Just wanted them to discuss it.
Yep.
Because that's the issue. Well, in the next hierarchy, or next poll, we can discuss, see what people want to say about their answers about that too. I can ask them if anyone wants to share anything here too.
Yeah.
All right, looks like some good discussion there about philosophy. All right, anyone want to share their philosophy of treatment and why they think they've chosen that one? What do you think? Yes. Oh, we'll wait for the mic to get there so I don't have to repeat everything you say.
It may sound like a cop out, but I think it depends on, what you do, what your main population that you serve is.
Mhm.
With me, it could be any one of those any day.
Can you give an example?
With the more severe kiddos, I'm not thinking as much as function.
Mhm.
But with someone more active who's working, that would be my primary goal or one of the main focuses.
Mhm. Okay. Great. Any other? Yep, we have someone over here. You can get your steps in today. Thank you.
Yeah, interesting. Our row here, we all said functional. And one of the things, the example I give a lot in presentations as well is, if I've made this client look perfect, but I've taken away their ability to transfer independently, what have I really done for them? And we gave the example of a muscular dystrophy client. We all kind of have had one, it sounds like, who, are stacking, they're in that obliquity and they're stacking and they want to sit more upright, they're reducible, and you do that, and all of a sudden they can't drive their power chair. So, again, what have I done for them if I've made them straight and look perfect, but now they don't have their independence?
Yeah, that's a great example because that population, when you're dealing with someone who has certain muscular dystrophies like Duchenne muscular dystrophy, absolutely that you're not going to win that battle anyway. The client's going to say, no way, I'm not going to sit that way, right? So that's part of that consensus, because in that scenario, typically we have a client who's going to say, I know you want me to sit that way, but I'm not going to. I don't like it. I can't do what I want, or I'm uncomfortable and I just don't like it. So ultimately, when we're building consensus, the most important person is the client, right? Client-centered isn't just something we say. We've got to, this is the person who gets to take this home and live in it. So not me. Want to make sure that that's something they can live with. Okay, here comes the mic.
Case, isn't that still function? Because once you realize you've taken it away, go back and reassess to give them the function back.
Yeah, I think that's what they're saying is function was where they fell out. It's more of that. Yeah, definitely.
Yeah, I was just going to say, it's interesting because the perspective again, with adults, they tend to make the choice. But with pediatrics, so often I think one of the things we deal with is parents are trying to trump the choice. And one of the things I heard so often in my practice was make them straight, make them straight, make them straight from the parent, and I'd have to say, well, one, I'm not a surgeon, right? But two, you're trying to explain the functional piece of it, but the parent's continuing to say, no, make them look straight. So just curious,
Mhm.
maybe how you deal with some of that.
Right.
So I do have a comment. If I can.
Yeah, go for it.
So you guys talking about function, everybody's selecting function, right? Function is the big thing right now, which I agree. But what is function? It's just driving a power mobility chair or pushing a chair. Could it be that I make my client breathe better? And to do that, do I need to be more concerned of the alignment, for instance? Or just
That's a great point, is what are those functional goals for that individual? You mentioned a client who's very involved, and I've certainly seen some clients that are at a very, very low level of the coma scale, for example, minimally responsive. And so goals are very different than someone who may be operating a speech generating device or a power wheelchair or transferring or the other activities like that. But I think there are still definite goals beyond simply aligning a person. It makes our job more difficult sometimes to determine, do we think this person is as comfortable as possible? Are they able to manage their secretions as well as possible? Can they, is their breathing as optimal as possible? Our goals might change, but I think you can definitely make an argument that's still function. It's a medical function. It's a bodily function, and that's also very important for us to consider. Yep.
Times when you see somebody and if they don't sit appropriately right now, that they're going to develop postural issues down the road.
Mhm.
And so right now you may want them some way, but what's going to happen if you don't sit them properly, and then you're screwing function in the long run.
Mhm. So that's a good point. You have a client who maybe, like with the example of someone with a muscle disease, might say, I don't want to sit that way. But we know what the long-term consequences might be if they do, and that could ultimately impact their function. So what do we do in that situation? Anyone have some suggestions? I see some nods up here. Yep, education, great. So educate on the pros and cons. I think we all have illustrations, because I have like 6 of them coming to mind now. But I think that we need to let team members know, here are, in our opinion, what could perhaps occur, because none of us know exactly what will occur in this client, but here's what our concerns are, pros and cons. But ultimately, that final decision is not one that I may always agree with. Depending on the final decision, I'd love to know what you think about this, Filipe, in your area of our world too. There have been a few times where someone has made a decision that I don't feel that I can support, because I'm of the type of decision they're making. Maybe there'd be harm caused. And in that case, I have to decide, do I feel comfortable documenting a recommendation that I'm concerned about? So I hate to give an example, but I'll give a really brief one. I had a client recently I've really felt needed a molded seating system. The therapist involved with the child said no. They were worried it would restrict movement. I'm worried that her curvature is getting worse really rapidly. So they asked me to recommend the next best seating system, because they didn't want molding. I asked them if they knew what that was, and they said no, because I was the expert. I said, well, I really think she needs molded seating. So I said, okay. So the supplier and I discussed options with the team. And we came up with something else, but I did let her know I was concerned that this curve could worsen. Her doctor had told her, don't worry, if the curve gets worse, then we'll get a molded seat. I needed to let her know that in the reality of our world, that may not happen as readily as she thinks, because if we get funding approval for option B, I can't just come back in a couple months and say, oh, that didn't work, because I already kind of knew it wouldn't. And I had to document respectfully, because the family is the only one who ever reads that whole report, that our first recommendation was something different. Because eventually, if someone comes back and says, hey, what happened to this kid's back? Why didn't you recommend molded seating? I can say, well, we did. But my decision wasn't the final decision. I needed to respect the family. And I still work with them. So education was part of that. Documentation was part of that. Parent-centered was part of that, because this is a girl who isn't in a position to make that decision. We have a mic here.
So that comes back to my question that I had in the beginning, is that transition aspect of it. Okay, you went through the option that you didn't want to. We find that this didn't work very well. Then we transition. What's the language that's used typically for that? How long do you wait? And like, how do you engage your team members in that conversation? Not saying you were wrong, I was right.
Yeah.
But we're so saying like, I see this is not working, you know.
Okay,
Maybe
so
something that-
are you saying that eventually, if there's indication of need of molded seating still, when do we re-engage with the family and say it's time now?
And the team.
And the team, definitely. What I did when we recommended this and it was provided is I also tried to educate the parent, especially in the situation of what to look for that indicated that we needed to reevaluate her daughter, including growth, but other changes. We also did a sleep positioning evaluation because a lot of her changes in her posture, I believe, were because of her sleep position. I hope mom is following through with the sleep positioning. I should write myself a note and check when I get home on Monday. But, looking at all of her positions, other strategies we could use to minimize that risk. But eventually, because I do see her periodically, if we notice enough of a change, if she's outgrowing what she has and we think that enough time has gone by that we could look at something else, we can revisit it with the team and see if they're open to looking at a different option at that time.
And I work primarily with adults and older adults. And at what point, like, do you re-engage in the sense of like to prevent rather than before seeing signs? Or if you see one sign, like when is the trigger for you?
Oh, boy, that's a good question. You have any good ideas for that one?
That's a tough one. I think what Michelle said in the beginning, to document everything, right? Don't get me wrong, we're here to talk about building consensus, but sometimes it's really difficult, right? And sometimes you just, take one for the team, right? Which is bad, right? But it is what it is. I think documentation is, we need to protect ourselves at all times because we are responsible for what we're doing. Okay. And we need to make sure that we push and fight with all the element of our team or the team members with our ideas and justify why we think that this is not the way that we need to go. But then in the end, this is still a democracy, or it should be, right? And if everybody else it's disagreeing with us, I think that there's not a lot that we can do, right? So eventually having a recurrent access to the client and see how he's developing will allow us to rapidly, and I understand that funding is a problem, like we said in the beginning. especially here in the US, right? There are other countries that probably is easier to work that, and if you make a mistake, or if we make a mistake is a strong, a strong argument, but if we decide that we probably could do a better choice, we have time to go back and just try to amend that. Here in US, it's probably a little bit more difficult. So, but again, having access to the client and just checking the client in short periods of time so that we can act if we need it.
In answer to your question, I think if you're gonna want to know, you wanted to know when, at what point do you say, okay, we've reached the trigger. Set it up when you do the initial setup. Set up, okay, you've voiced your concerns. Go ahead and tell them, okay, reach consensus on where do we go if there's a problem? What is going to constitute a problem and how are we going to identify it? Okay.
Yeah, I think that's excellent. You set up those parameters and then you revisit. All right, let's go to our final example here. And then we got another poll, our last poll. So let's say we go back to this client who is in a school classroom. The school PT does not believe the client needs a new seating system, but the evaluating therapist and supplier see some significant seating concerns and do believe a new seating system is in fact indicated. So what is our common ground when we have this difference of opinion? Whoever has the most credentials gets to decide. The parents choose who gets to decide. The parents ignore all of them and go to an outpatient seating and mobility clinic or optimal positioning for the client. It's fun to be able to use your phones during a session. As long as you don't see how many emails you've gotten during ISS. I'm trying to ignore that. All right, I think we're about done. So it looks like most people have chosen optimal positioning for the client as a way of building consensus. So again, this isn't who wins. This is no matter how we get there, how do we find the best positioning for this client? And that might allow these two groups that are disagreeing to have a discussion instead of at the level of they need a new seat, they don't need a new seat. Do we agree that they need optimal seating? Now let's look and see, is there optimal seating or not for this client? And if that might allow us to get past some of those egos and disagreements and get to a level where we can have a better discussion. Not always. All right. So there is an unspoken hierarchy of rules, right? That's out there. And if someone is higher than someone else on that hierarchy, they might have an opinion that's valued a little more. But playing nice with each other means that we need to remember that everyone has something to contribute. Even if that person is kind of annoying, even if that person is maybe on the hostile side, or what, maybe you have a personality clash with that person, we are there to build consensus so that we can meet the client's interests. We're not evaluating a client to try to impress other people. We want to come up with a goal, or I'm sorry, come up with an outcome, a successful outcome for the client. All right. I think we need some chocolate while you talk about rules of engagement. Yeah. All right.
Guess you're ready, huh?
All right, who needs chocolate? Everybody.
So rules of engagement, leave your egos at the door. Okay, remember that our main goal is our clients and making the best we can for him or for her. So it doesn't matter who's the boss. It doesn't matter, the level of my knowledge, how good I did in the past. What matters is that I leave my egos at the door and I'm ready to have an open mind for discussion. Like Michelle was saying, we have a lot of different team members. We have a PT, OT, a speech therapist. We have probably the supplier. We have the caregiver. We have the family. Everybody should have a voice. Okay, so we need to listen to everybody and eat some chocolate while we do it. Okay. So empathize. Let team members know that you heard them, although you don't agree with them, but let them know that you're hearing them, that their voice means something. Okay, that's really important. Ask for input, just like Michelle did with me right now. Okay. Right, so it's really important to find the common ground and the problem solver solutions that address the core issue. Okay, so ask always for input for everybody because everybody has something to say. Educate if you need to, but with respect. Okay, sometimes the tone of our voice, the look that we do to someone's comment, it's kind of messing the mood of the team, right? So be careful with that. Always be respectful to everybody in the team. Okay, so our goal is to successful client outcomes. Okay, that require optimal recommended interventions and equipment. This is all about the client. Never forget that. Funding approval, and I think everywhere in the world, funding is important. Funding approval is important, and it's also important that the client is using the equipment. Okay, we have a lot of examples where we spend a lot of money equipment that is just on the garage or in the room because the clients are not willing to use it, or the parents or the caregivers, right? So building consensus improves these outcomes. Okay, so just be nice to each other. Okay, questions? Yep. Thank you guys for coming. Oh yeah, we have a comment there. I'm sorry.
We have some sorry. What strategies have you used if you are working with a supplier or a vendor rep that maybe is someone who has opinions so strong they don't back down about those situations in front of the family? I feel like that's something that we encounter a lot in our clinic because we have really strongly opinionated ATPs that sometimes make the family really uncomfortable. And then I feel like I see the family backing down, and I want OTP to ATP to be united front to present like, hey, this is I don't know. I feel like I struggle with figuring out how to help the family have a positive experience in the medical community. And I struggle to know how to intervene in those situations. Maybe that's more of a private question, but I am curious.
You want to take that? You want to ask it? Yeah.
Well, what I would just briefly say on that, since we're running out of time here, and then very happy to have people come up afterwards as well, is that's probably a good conversation to have away from the family. So I would ask that team member to come and meet with me separately and just have a discussion. And even then, make sure that person doesn't feel shamed or condemned or anything, just to say, hey, this is our goal during these evaluations, and how do we work together so that the family feels like they have a voice and we certainly don't want a family to feel intimidated into making the decision that the rest of the team wants them to, right? And I would have that discussion with them. And if you still don't get anywhere, it's kind of extreme. and I'm not trying to bash suppliers at all, this could be any team member. Certainly, there's been times where we have a team member that is so difficult to work with that we've had to ask that person not to participate in the evaluations for a while. And if it got to that point, because the client and their voice needs to be heard. And if that person can't play nice in the sandbox, they have to go to timeout for a little while, right?